So, welcome to the GFB webinar series. My name is Carlos Sanchez, and I'm a member of GFB Foundation. And for more than 10 years, our organization is making efforts to understand sarcoglycanopathies, and is making efforts to build a community of actors, the patients, doctors, industry. And our goal is to help us to help patients living our life in the best possible conditions. To this aim, recently it have emerged several clinical trials concerning LGMDs, demonstrating that science advances slowly, but is moving forward. For that reason, we found very important that today, the International Day of Rare Disease, we could have a summary of the current clinical trials that are being developed worldwide. To speak on this argument, we invite the Dr. Jordi Diaz Manera. Jordi is a professor of neuromuscular disease and translational medicines in genetics in Newcastle University. He has trained as neurologist in the Hospital of San Pau, Barcelona, Spain, and during more than 20 years have been worked there, and then have moved to Newcastle to join the John Watson Muscular Dystrophy Research Center, where it's combining clinical and research work. Jordi's interest in research are imaging techniques to diagnose and follow up the patients, but also basic research understanding the process of the muscle degeneration in neuromuscular disease. So we welcome you, Jordi, and now the floor is yours.
Thank you very much, Carlos, for the kind introduction. I'm going to share my screen, and I just need to know if you can see the slides.
Yes.
I'm going to put them in presentation mode. Then I'm happy to start. So as you said, it's for me a real pleasure to be here. Thank you for inviting me to give this presentation. I remember that I talked for the first time for the Italian Association of Patients with Beta Sarcoglycanopathy many years ago in Venice. They invited me also to give a talk about MRI in that moment. The talk that I gave in Italian. Now I'm changing to English because I think the audience is broader. You have people from everywhere in the world, I think. And it's as I said, it's a perfect coincidence that I'm giving this talk the day of that we are celebrating rare diseases around the world. So as you said, I'm going to focus on clinical trial landscape for Limb-Girdle Muscular Dystrophies. And so this means that I'm not going to talk too much about what are Limb-Girdle, because I guess that everybody here knows that these are a group of rare genetic disorders that are produced by mutations that encode proteins that are expressed in the skeletal muscle. So these diseases can be inherited as recessive or a dominant way. They are more than 30 different types that are, some of them are relatively frequent among other neuromuscular diseases, while there are others that are very rare. And in general, in these diseases, there is always a protein that is lacking, and a deficiency in this protein leads to muscle damage through different ways, leading to a progressive loss of the muscle fibers and replacement by fibrotic and fat tissue. And this is what produces the patient's disability. And as you know, there is not a treatment for these diseases that can modify the natural history. Okay, so I think that when we talk about therapies, we need to understand the process of muscle degeneration. And you said that one of my interests is understanding this process, and this is right, because I have been always interested in identifying the molecular pathways that can lead to these different stages. So I very often start my presentation with this slide where I basically say that the process of degeneration has different stages, different steps. So we start with a muscle that can be relatively healthy, but because the lack of this protein, this is going to lead to muscle fiber injury. We will have inflammation. We are going to have muscle fibers that die, and then these fibers are substituted by fibrotic and fat tissue that for a while will be together with muscle fibers that are still there. But in the end stage of the disease, we'll have a muscle that is completely atrophic and is replaced by this fibrotic and fat tissue. So fibrotic and fat tissue contributes to muscle weakness, but also contributes to muscle disability and also to contractures, stiffness, and sometimes pain. So we can act through all these different stages. So when we consider strategies for treating patients with Limb-Girdle, we need to understand that we have different options. So we could start, for example, trying to restore the protein expression or the function of that protein that is lacking. And today you will see that most of the talk is going to be focused on this because most of the Limb-Girdle, the trials that we have in Limb-Girdle are trying to use gene therapy to bring back a healthy copy of the gene in a way that the muscle fiber can express the protein again. But we need to understand that there are also other possibilities that can be combined, like, for example, tackling the inflammation that happens early in the disease, or, for example, reducing the fibrosis and the fat expansion. And we could also consider increasing the amount of muscle tissue. This is in the old times we used to do research with the stem cells, trying to put new muscle, but this is something that is now a bit not as popular as it was some years ago. So let's start with the first strategy, which is basically restoring the protein expression. And for this, we need to talk about gene therapy. So gene therapy, basically, I can define this as a therapy that aims to restore the protein expression in cells or tissues by different ways. It can provide a new copy of the mutated gene. This is what we are going to discuss mainly here. It can also try to fix the mutation or can also try to skip the mutation. So skipping the mutation is very relevant in Duchenne muscular dystrophy because there are many drugs that have been tested there, but it's not so relevant in Limb-Girdle muscular dystrophies. And fixing the mutation using different strategies like CRISPR-Cas technology, for example, is something that is not still ready to be tested in clinical trials, at least in Limb-Girdle muscular dystrophy. So let's talk about what we consider gene therapy. So when people talk about gene therapy, we should understand that there are multiple different ways of different types of gene therapy. But basically, what everybody means with gene therapy is what we call gene delivery. And when we do gene delivery, we need what you are seeing here on the screen. So we need a copy of the gene that we want to transfer to the tissues of the patient. We need our courier that is going to uh, bring this gene, this healthy copy, to all the cells of our body. And we need, of course, the tissues that we want to target. Okay, so let's talk a bit about all these different components of gene therapy. So the first one is what we call the transgene. So what we are basically doing, what the companies are basically doing is kind of factoring a gene that is an artificial gene that contains either all the components of the original genes, the healthy genes, or sometimes they try to do genes that are a bit smaller and that contain just the essential parts of the protein. In the case of Limb-Girdle, the genes that are developed or constructed in the laboratories are exactly the same that we could identify in a healthy person. But this is the first thing that we do. So we need to really develop a construct, develop a gene that is going to be healthy, that is going to contain all the components of the gene and is going to be transfected to the cells. Then we need, as I said, our courier. And you need to imagine this like a van that is going to transport the gene to the different cells. And this van would have been so in order to identify the best van, there are many different experiments that have tested virus, which are nowadays the usual one used in clinical trials. But there are other ways, for example, of transporting these genes, like, for example, nanoparticles. We are going to talk only about virus today. So which virus? If you review all the studies that have been done all along the years, these are the viruses that have been tested either in cells or in animal models of muscular dystrophies. So, for example, they have been tested retrovirus, lentivirus, herpes virus, adenovirus, and what you call now here, or what we understand are the best one, the associated adenovirus. The last ones are the ones that we use in clinics. And there, you can see here that I have classified this virus in two different types, what we call the virus that integrate the genetic information and what we call the virus that do not integrate the genetic information. And this is very crucial to understand gene therapy. So what are these? Sorry, because this is in Spanish. I thought that I translated this. So what are the viruses that integrate the genetic material? So as you know, inside the cells, each cell has its own material, genetic material. And what these viruses are going to do basically is that when infect the cells, they are going to transfect the gene that has been developed in the laboratory, and this gene is going to be integrated with the rest of the genetic material. So it's going to kind of copy and paste. It's going to be to cut the sequence of the DNA of the cells and be then pasted there. So it's integrated into the chromosomes of the cells, into the genetic information of the cell. This is good because when the cells divide, what happens is that the information is also replicated, and the gene that we have now brought to the cells is going to be present in all the cells that come from the original one. So every time the cell divides, the information is replicated. But it has a problem, and the problem is with the risk of mutagenesis. What is this? Because what is going to happen is that the genetic information is going to be copied randomly in the DNA of the patient. Sometimes when it's copied can induce some mutations. And this means that, for example, in the virus that are integrated, sometimes we can have cells that start proliferating because we have produced a mutation that can induce a cancer or can induce another disease. And this is the risk of using viruses that integrate. And that's the main reason why these viruses are not commonly used nowadays in clinical trials, because it can be very hard to predict if they are producing a mutagenesis or not. So what we use is viruses that do not integrate. So basically what happens is that we have our virus that infects the cell. And here what's going to happen is that the genetic material that is transfected to the cell is not going to be integrated. It will create an artificial chromosome, what we call an episome. And the main problem with this is that when the cell divides, this genetic information is lost. So it's not going to be passed to the cells that come from the original one. The main advantage, of course, is that we don't have mutagenesis, but the main problem that we have is that when the cells divide, the information, the genetic information that we have just given to the cells is lost. So if we are willing or if we are aiming to treat a disease that affects a tissue where the division of the cells or the cells are dividing constantly, like for example could be the bowel system, the bowels, or the skin, for example, sometimes the liver, where there is a high rate of cell division, gene therapy with these strategies will fail because means that after just a few months, all the cells have divided and then the information is lost. But if we want to treat a disease that affects a tissue where the cell proliferation is very low, for example, the brain, for example, the muscle, this is a good strategy because it means that the information can be there forever, as it happens in the brain, or for a long time, as happens in the muscle. But I think that this is an important concept that everyone needs to understand. In the muscle, when we have a muscular dystrophy, even in the best scenario, imagine a treatment that works perfectly well, the disease is not completely cured. And means that there is always some proliferation of the cells because the cells are trying to fix the damage of the muscle. And this means that we will have some dilution effect. So the information is going to be lost progressively. So for how long, we don't know. But this is one of the problems that we have with gene therapy. Okay. So I hope that this is clear. So this is the normal structure of a virus. So a virus, an adenovirus. So these adeno-associated viruses are the ones that we use, and the main reason why we use them is because they are very good to infect many cells, and they are these are artificial viruses that do not exist in nature, and based on what we call the adenovirus. So adenovirus produce many different diseases. They can produce, for example, in respiratory infection. They can produce diarrhea. And what we know is if we look at the adult population, around 30% of the adult population has been in contact with adenovirus once in their life, because all of us, we have had a cold or we have had a diarrhea, gastroenteritis, and it's very frequent that these are produced by adenovirus. But when we are infected by adenovirus, the genes that the adenovirus, the normal ones have, are these two genes. One that are in charge of producing what involves the gene, which is the capsid, and another one that are genes that are involved in replicating the virus, so in making that the virus can reproduce. So what we do when we build an adeno-associated virus is that we remove these two genes, and we are just going to put our gene of interest inside. So this means that we are going to infect people with a virus. This virus will arrive to the cell, but this virus is not able to reproduce. Different to what happened in diseases, where the number of virus grow because the virus can reproduce, can replicate. In gene therapy, the number of virus will never grow because we have removed the genes that are involved in the replication of the virus. So we use adenovirus, as I said, because they are not inducing mutagenesis, because they in fact trigger very low inflammatory reaction, because they have a high capacity of infect tissue. But I think that this is another important concept. So we need to understand that the skeletal muscle is the most abundant tissue in the body. So if you weigh 70 kilos, probably 35 kilos or even 40 kilos are just muscle. So muscle is huge. We have millions of muscle fibers, and all these muscle fibers need to receive multiple copies of the gene. So what we need is to have a lot of virus arriving to these muscle fibers. So imagine that you are working for one courier company and you have your van, and then you want to distribute a group of parcel between these houses. So if you are working in a small town, this is mainly easy to do with just one or two vans, right? But what happens if what we want is to distribute parcels in a city like, for example, Barcelona, where there are 4 million inhabitants? So you need a lot of vans. You need a huge amount of vans that can then arrive to all these houses and deliver the parcels that you want to bring, right? So that's the reason why when we do gene therapy in patients with muscular dystrophies, we are injecting a huge amount of viral particles. This is the number that we sometimes manage. It's 1 or 6 per 10 times, for 14 times the number of particles. So these are millions of billions of viral particles that are injected into a human just in half an hour. So this is what happens when we do gene therapy. Patients receive all this amount of particles in just half an hour. So there are some challenges that we have with gene therapy. Once these cells are injected, when these viruses are injected, because of the normal circulation of the blood will go directly to the liver. And the liver is an organ that depurates the blood. So the AAVs, most of them are going to get trapped in the liver. So in general, 70% of what is injected get trapped there. And this is the normal function of the liver. So it's normal that this happens. And this is going to be the cause of that some patients can develop a bit of liver inflammation. But after that, the blood will go to the heart, and from there it's going to be distributed everywhere. So what is important to understand is that the AAVs that you inject go everywhere. So they will arrive to the muscle, but they can also arrive to, for example, the skin, the kidney, the eyes. They can also arrive, for example, to the bone, to many different tissues, okay? Nowadays, we are developing these AAVs that are specific for muscle. And actually, of all the AAVs that we have available, there are two that are commonly used, the AAV8 and the AAV9, and also the AAV RH74, that is the one that Sarepta uses, because these have a specific trophism for the muscle, because they like the muscle a lot. But I want to clarify here that these virus will arrive everywhere. As this is one of the problems, because means that of all the virus that you have injected, only a small portion will arrive to the skeletal muscle. One of the trendy things that we see is happening in gene therapy is the development of what are called myo-AAVs. So these are virus that identify some molecules in the surface of the muscle are specifically targeting the skeletal muscle. So are trying to reduce the loss of virus by increasing the targeting of this tissue. However, this is not perfect. It means that we still have a lot of virus, even in these cases, that are lost because they are trapped in the liver or they are not arriving to the muscle. But with these myo-AAVs, I think that we think that in the next year we will increase the amount of virus that arrive to the muscle. Okay. So then we have the concept of the promoter. And this is an important one. I have just said that the virus will go everywhere in the body, so they can arrive, for example, to the to the kidney, they can arrive to the bowel system, and then we just want our gene of interest to be expressed in the muscle. So for that reason, what we use are promoters, and these promoters are muscle specific. So are molecules that are only expressed in the muscle and will mean that the gene will only be expressed, will only produce protein in the skeletal muscle fibers. So this means that if you have a patient that has received the therapy, the gene will arrive everywhere, including the liver, but the liver will not start producing sarcoglycan protein because sarcoglycan has nothing to do with the liver. The only tissue that will produce the sarcoglycan is the skeletal muscle or the heart muscle. Okay, the promoters are therefore important. And then we also need to talk a bit the adverse effects because when I talk to patients, what I see is that many patients, there is a hype now with AAVs and with gene therapy, and everybody thinks, oh, this is going to change radically the natural history of the diseases. And it's true that we are really happy and enthusiastic about these therapies, but we need to take this carefully. And I think that everybody needs to understand that we need to do the trials, not only to understand the efficacy of the drug, but also to characterize what are the adverse effects, because these are new treatments. So are treatments that are absolutely new. We don't know anything about them. And what we have seen in the patients that have been treated, and this is something that comes also from my own experience treating patients with gene therapy, we have different types of reactions. So we have what we call inflammatory effects, we have immune-mediated effects, and we have also antibody production. So let's go a bit through all of this one. Let's start with antibody production. So I think that's important. So when we are infected by a virus, the human bodies, we always develop a response that try to defend us from the virus. And this response is production of antibodies. So the antibodies, basically, what they are going to do is to recognize the virus and kill it. And this is, as I said, important because protects our body and we don't die of virus infection in many occasions because we have this system. As I said, at least 30% of the population have been in contact with adenovirus before, and means that they already have antibodies because the antibody lasts forever. And when you have a patient that have antibodies and you treat them with gene therapy, the response is very low. Why? It is low because the antibodies will destroy the virus that you are injecting. That's the reason why patients that are called seropositive, means that they have high levels of antibodies against the adenovirus, cannot be treated in clinical trials because their response will be very low. But the second important concept is once you have received the treatment, then you will start immediately to produce antibodies because it's the normal response of your body. And this means that reinfusion, which means that you are treated again in 5 years' time, 10 years' time, is not possible unless we either immune suppress the patient or we change the virus. Okay? So nowadays, there are some trials, not in Limb-Girdle Muscular Dystrophy, but in other diseases that are testing immune suppressors. So drugs that reduce the capacity of the body to produce these antibodies and are testing the patients with and treating patients with immune suppressor before and after the treatment with the main aim to reduce the production of antibodies. Okay. So probably in the future, patients that receive gene therapy will probably be treated with immune suppressors to reduce the production of antibodies. So this is basically what I meant. Another important concept is, as I said, the inflammatory reaction. So when we treat a patient, as I said, we need to understand that these patients are going to receive a massive amount of virus. And in general, it is normal that during the infusion or a few hours after the infusion, patients can develop some adverse effects that tend to be very unspecific and can be related with the fact that they are being infected by a virus. This can be fever, a rash, feeling a bit sick, nausea. This can last for a few hours in some cases, this can last for few days. For example, in a recent patient that we have treated in a trial, the patient developed severe nausea that lasted for at least 1 week. So this is the normal general inflammation response to the virus. But then you can have also tissue-specific inflammation, and the most frequent one is the liver. So the liver, as I said, is the organ that retains most of the virus, and most of the patients are going to develop, most, if not all, are going to develop some level of inflammation in the liver, hepatitis. This is easy to treat with steroids. So if you put steroids, patients are going to have less inflammation. But sometimes we require to treat the patient for long, more than 2-3 months with steroid to control that. Other tissues that can frequently be inflamed are the kidney and also the bone marrow. So patients can sometimes develop anemia, plaquetopenia, or what we call thrombotic hemolytic uremia, which is a severe disease that can require the treatment with eculizumab. So as you see, just because you have been treated or patients receive a treatment with a virus, there are some systems, there are some tissues that can be inflamed, and these are complications that we see in our patients. In order to reduce the inflammation, what we do is to treat all the patients that receive gene therapy with steroids at least 1 day before the infusion and at least for 2 months. Depending on the protocol, this can change a bit. Okay, so basically what happens when we do gene therapy is that we have our virus, the virus is injected into the blood, then the virus arrives to the muscle, enter into the muscle fiber, goes to the nuclei, it opens, release the gene, and this gene is going to be starting to start producing the protein. And imagine in a muscular dystrophy where we want to produce sarcoglycan, then the protein will go to the membrane, and then it will start doing its normal function. So what is the story of gene therapy in Limb-Girdle Muscular Dystrophy? So this is not a new thing. In Limb-Girdle Muscular Dystrophy, there have been some studies in animal models, and we always need to go to the animal models to confirm two things. One, that the treatment works, and second, that it's safe. But you can see here on the screen some papers that I have selected where the results of animal models were studied, and this gene therapy in alpha sarcoglycan, gamma sarcoglycan, there is also beta sarcoglycan, dysferlin, alpine, so many different link inverts. And when we use animal models, we want to always demonstrate different things. Mainly, I would say 4 different things. The first one is that the gene is working. So it's producing the protein. And you can see that we can study this using different ways. For example, immunofluorescence. And you have here a tissue where the protein is not there. And after the treatment, we can identify the protein, which is this red line in the surface of the muscle fibers. Or we can, for example, use Western blot, which is this technique that allows us to identify the proteins as bands. And you have here an animal non-treated, and these are the animals treated, showing that the protein is there. Or we can also look, for example, at the RNA, so at the amount of genetic material that is the cell producing, and we can see that there is an increase in this genetic material that is dependent of the dose of the number of virus that have been injected. So the higher the number of virus, the higher the amount of gene that is produced. That's the first thing. So the gene is there. Second thing, we want to show that the protein is working. So it is not only there, it's functional. And then there are different strategies to do this, different functional studies that can be developed. I am not going to go into too much detail into that are easily done with the tissue. We want to see that there are changes in the tissue structure. So the tissue, which is very bad before treatment, showing dystrophic changes like inflammation, fat, fibrosis. After the treatment, the tissue is far better, showing restoration of many of the problems that were present before. And we want to see also improved muscle function. So the animals that are treated or the patients that are treated have a better muscle function test. No? So for example, here in the mice, we always look at the distance that they cover when they walk or a specific force. And we also look at biomarkers in the blood like creatine kinase, which is a marker of muscle damage, or AST, which is another marker of muscle damage. And we see reduction of these markers of muscle damage. So this is basically what we do. So what is the experience that we have? So in Limb-Girdle, as I said, there are many studies that have studied gene therapy in animal models and successfully. And now the first thing that happened is after that, some studies started doing intramuscular injection. So this means that instead of doing the injection systemically to the blood, they were doing just intramuscular injection to confirm that the gene therapy was working. And this, I have to admit that for this, the group of Jerry Mendel in Columbus, Ohio, was a pioneer because they started doing all the studies with the sarcoglycanopathies, the alpha and the beta. And I remember when I read this first paper, that was very excited because they did an injection of the virus in this small muscle of the foot of one patient, and they observed in this muscle that the protein was there. You see the immunofluorescence and the Western blot, the protein was there in the treated patient, and also that they observed that the muscle, the structure was better, but they also observed there was a bit of inflammation in the muscle, and they observed these antibodies that were produced. Remember what we have mentioned, antibodies in the patients after injection are go up. So what is the experience that we have with the systemic delivery? So when I was preparing this talk, I thought that we could probably talk about Duchenne, but I think it's not fair because we are talking about Limb-Girdle Muscular Dystrophy. But I do think that it's important that everybody knows that all these techniques have been basically tested before in patients with Duchenne. And it's thanks to these studies in Duchenne that we have now gene therapy in patients with Limb-Girdle. So in Duchenne, there have been several clinical trials, even phase 3 clinical trials that have tested gene therapy with systemic delivery. So this means intravenous injection, and the results are variable. So there's some studies have failed to demonstrate any efficacy of the drug. Some studies have been stopped because of adverse effects, but other studies, especially the one done by Sarepta, has succeeded to show improvement of the patient in the short term. And as you know, this treatment is now approved in some countries, especially in the States, United States, and the regulatory authorities are they're asking the company to provide data on efficacy in the long term because it's what we don't know. We don't know what happens after 4 or 5 years of treatment. So thanks to this study, we can also say now that we have clinical trials in other diseases. And this is the first study that was done with intravenous injection in a Limb-Girdle muscular dystrophy was in beta sarcoglycanopathy. And in this study that was done by Sarepta, you can see here that 6 subjects, 6 individuals were treated with this drug, what is an adenovirus carrying a healthy copy of the beta sarcoglycan gene. And as you can see here, there were 2 different doses, a low dose and a high dose. 3 subjects received low and 3 the high. And the ages the patients included were young patients between the age of 4 and 15 with a mutation confirmed that didn't have the antibodies and that were ambulant. And all of them were treated with steroids. So you can see here some of the results, and the results show that the higher dose were more effective, as you can see, because they could observe the presence of the protein, as I explained before, in more fibers, up to 70% of the fibers expressing the protein, and they could observe that the amount of protein was more or less 60% compared to a control. So the control has 100%. So these muscles, the muscle biopsies show 60% restoration of the protein, which is a high amount of protein. And this is a bit the progression of the patient. So you can see that patients improved in their muscle function for the first year of follow-up, which is, of course, a good result. It's so good result that now we have a phase 2 clinical trial, the Emergene clinical trial that has been done in United States and some hospitals in Europe. We have been lucky enough to do the study in 2 patients and treat 2 patients in our center in Newcastle, and it has now finished recruitment, and now we are following up the patient. So the results show that the treatment is safe. So far, there have been no adverse events, but I don't have any data about the results of this second study that has been done with a total of 15 patients. So if you ask me, I will not be able to say anything because I can just say that the patient have been treated and we are following up them now in clinics. But of course, these positive results have now launched a lot of expectation. And you know that Sarepta is also planning to do clinical trials in other types of muscular dystrophies that basically include not only the beta sarcoglycan, but also the alpha sarcoglycan and the gamma sarcoglycan. So we are going to do all these two studies in our center in Newcastle, and there are some European centers where I think that these studies are going to be done as well. And they are also planning clinical trials in other diseases. For example, in dysferlin, they have a phase 1 study now ongoing, and they are including some patients that have been treated and analyzing the results. They are planning a clinical trial in calpain that is also going to happen probably in 2026, and hopefully we will be able to do the study as well. And for patients affected by anoctamin 5, the news are that probably this study will come a bit later, 2027 or 2028. So let's see what happens with these studies. Just uh, just to tell you that Sarepta is not the only company, of course, in this field. There are other companies, and one of the other companies is Atamayo, which is a French company that was basically developed in the Institut de Biologie in Geneton, and they have also a gene therapy program. And if you go to their web, you can find information about the gene therapy programs that they have. And they have two programs already in clinic, so they are already running. The first one was a gene therapy study that was done in patients with mutation in the FKRP gene, which is the 2I or the R9. And in this case, they treated 4 patients. There were no adverse effects, and they observed good results. So there was a decline in the levels of creatine kinase in 3 out of the 4 patients. The patients, as a mean, they improved the velocity when they were walking, and that was sustained over 1 year. Some of the symptoms that patient reported, like cramps or muscle pain, disappeared, and there was an improvement in the quality of life. And there was also some correction on the muscle structure. But they have also another clinical trial with gamma sarcoglycanopathy that's going on. And they, as you can see here, are planning other trial that, as far as I know, have not arrived to the clinics. Okay, so we have reported some things. One is antibodies, that the trials, then I have mentioned about the antibodies. So, but for me, as clinician, the main concern is this response that we are observing, for how long is going to last. I think that this is the key question here is, okay, if this is effective, is this lasting forever? Is this lasting for 5, 10 years? What happens after that? How are we going to monitor the patients? Can we retreat patients? That are questions that are still open. So we are super enthusiastic with these therapies, but I think that there are many questions that we need to solve. Another important one is this one, the production and the cost. So the treatment cost 2 million per injection. This is the cost of the treatment of gene therapy. So it's important to understand that for the health system, it can be difficult to pay for all this. And we need to also put that into the equation and discuss with the companies and with the payers, how are we going to deal with the cost? And another important one is the production. So as you can see, we are producing millions of viral particles, but the production plants are not many. So it is not realistic to think that if these treatments are approved, tomorrow we can treat all the patients that exist in one country with Limb-Girdle Muscular Dystrophy, because we cannot produce enough drug. So this is something that needs also to escalate. Okay, I have just a few minutes, but I want to talk about other options because sometimes this is not discussed, and I think it's important. So one of the things that I wanted to talk is about other therapies that can, for example, be used. And this is a lot of the research that has been done in treatments that try to inhibit the proteasome. So what is the proteasome? The proteasome is the cell, it's an organelle inside the system, the cells that try to destroy the proteins that are abnormal. And as you know, in a muscular dystrophy, we have mutation that make our protein abnormal. And you can have a bit of protein, but this protein is destroyed by the proteasome. And some people have studied, for example, different molecules that can try to inhibit the proteasome to try to push the small amount of protein that is produced by the patient, and that this protein can arrive, for example, to the membrane and be functional. And these treatments, for example, have been tested in cells, and they have demonstrated to increase the amount of protein. But however, because they are very toxic, they are not usually implemented in patients with muscular dystrophies. Similar to this, for example, a group in Italy studied the CFTR correctors that are basically proteins that can modify the conformation of the proteins and try to bring these proteins to the membrane again. And this is applied to to patients with sarcoglycanopathy. So the idea is to develop a clinical trial for patients with this disease using CFTR correctors, but as far as I know, this is still not there. And something that is very interesting, and I think that some of you have asked if we could talk about this, is this story of the ribitol in patients with FKRP. So basically, I need to explain a bit the story. FKRP, it's an enzyme that is present outside the muscle fiber and is in charge of adding glycogen residues to this protein that is called alpha-dystroglycan. So these glycogen residues are important because they are going to bind all the extracellular matrix. So all the components of the fibrotic system or the extracellular system that help the muscle fibers to be anchored to the extracellular system. Without this, the muscle fibers are kind of floating in the muscle and then they start being injured. So in this story basically is that patients with mutations in the FKRP have a deficit in how they put the glycogen residues here. But in patients that have at least a bit of protein, so it's not that they do not produce nothing, they produce a bit of this protein. If we give a lot of ribitol, which is a sugar, they can start putting these glycogen residues again in the alpha-dystroglycan. And this is kind of, I have a protein that works just 10%, but I am giving this protein a lot of sugar. This way, the protein can handle that sugar and start putting this sugar back. And this is the basis of the treatment with ribitol. This is a treatment that has demonstrated to be effective in animal models. And you can see, for example, here that the alpha-dystroglycan levels are increased in the muscle, that the muscle fibers are better, and then they demonstrated that the muscle strength was increased in animals. And for this reason, there is now a clinical trial with ribitol that is called Fortify, and this is a phase 3 clinical trial that is still ongoing in patients with Limb-Girdle Muscular Dystrophy 2I, R9, with this sugar, this ribitol, and the results have not been released, but the study has finished to recruit, so hopefully we will have results very soon. This is a trial that is sponsored by ML Bio, so if you want to have more information, you just need to log into the ML Bio webpage. So for many years, there have been people trying to reduce inflammation in muscular dystrophies, and this basically mean treating patients with steroids. And for example, we had a meeting some months ago where as expert in sarcoglycanopathies, we just discussed the guidelines for how to follow up patients in our clinics. And we learned that some doctors are giving steroids to patients with muscular dystrophies. And this has been done because we can identify inflammation in the muscle. For example, in this fairly autoimmune find, it's very frequent that we identify inflammatory infiltrates. You can see the cells that are like eating the muscle fibers, or for example, in sarcoglycans or calpain is very common to find macrophages, so inflammation as well. So that's the reason why steroids are sometimes given, and the results are different. So there are some patients that can respond partially, but most of the studies that have been done with steroids are showing that the patients do not typically respond to steroids, okay? So this is, for example, a clinical trial that was done with this Ferlin, where patients were treated with eflazacort or with a placebo, and you can see that actually there were no differences between both treatments. So in general, except maybe there can be some exception, but patients do not respond to this treatment. Despite this, there are some companies like PTC Therapeutics, for example, that have tried corticosteroids in phase 3 in patients with R9, and there are some universities that are using steroids and treating patients with muscular dystrophies with steroids to understand if the disease the treatment works or not. So finally, I want to also comment on reducing fibrosis and fat expansion. As I said, this is a common feature of many muscular dystrophies with fibrosis increases and substitute the tissue. And there are some experimental treatments that have tried to reduce, for example, the amount of fibrotic tissue. And this is just a graph to show how many the number of drugs that have been tested. For example, we did a lot of work with this drug called nintedanib that tries to reduce fibrosis, and these treatments have been effective in animal models, but there have been no trials in Limb-Girdle Muscular Dystrophy so far. But not only that, there are also some academic groups that are investigating drugs that can reduce the production of fat. That, as I say, fat is another component of the tissue that increases in muscular dystrophies. So I think that in the future, we will probably have combination therapies using gene therapy and also anti-inflammatory drugs and also antifibrotic, pro-regenerative, or anti-adipogenic drugs. And finally, just a few words about increasing muscle tissue. I did my PhD in investigating the use of stem cells in this fellinopathy. And unfortunately, all the trials that we have done with the stem cells in patients have failed. So far, I think that it's a treatment that is far away from arriving to the patients because we don't know how to ensure that we have a lot of cells that arrive to the muscle and can really differentiate and produce new muscle. So muscle cell therapy in muscle, it's a concept that is a bit old-fashioned, and so far we don't have, or we haven't seen good results in the studies done. So I have been talking for at least 45 minutes now, and I just want to show you all these slides. So here you can see all the treatments that are tested in muscular dystrophies. So, and I don't have time to go through all of them, but this is just to show you that these are molecules that are being tested in animal models of muscular dystrophy. So the research that is now happening, it's incredible. There are a lot of products that we are testing. We are always talk about gene therapy, but there are other molecules that can arrive. And just a final reflection. I think that most of you are patients, and when I talk to patients, I always highlight the importance of knowing very well the disease. So we need to understand how is the disease. And this is something that we don't understand yet. We don't have enough information about this. So we need to identify how is the normal progression of a disease in a patient with a Limb-Girdle using muscle function test, to then be using MRI, using biomarkers, because this will help us to identify good readouts for the trials and understand what is the normal progression of the disease and how this progression of the disease is changed by the treatment, because so far we have some difficulties for that. So as I said, there is a lot of research. You have seen new therapies in Limb-Girdle. Gene delivery seems very promising, but I think that there are still a lot of questions that need to be solved. So we need to also investigate in the molecular processes that lead to process of muscle degeneration to identify new potential treatments, and the natural history is very important. And this is my last slide. I would like to thank you very much for your attention, and I'm happy to take any questions that you may have.
Okay, perfect, Jordi. Very nice presentation, very clear and very nice overview. And now it's the time for the questions. I think we have a lot of questions, and of course we have a lot of even very concrete questions because, as you said, we are on mainly patients. So patients are always eager to know about therapies and how to the progression on this. But we can try to transform that on more general information. For example, we have always the questions that how a patient can can be elected or can be selected for a trial. So I mean, it is important for the families or for the patients to know what is better, if to be of to apply to the registers to be localized, or even to contact directly the centers that you indicate, because the people is always very have a lot of ansia to have to access to
Yeah.
these trials. And
Yes, I understand. I
if
understand
you
perfectly.
can
Yeah, yeah,
give
yeah.
your point of
And
view.
I understand perfectly well. I think that, well, there are multiple different ways. So I understand that people is anxious and want to participate in trials because people see these trials as an opportunity to receive a potential therapy. And again, I always say the same to all my patients. So in therapy, in trials, we are not using a treatment. We are testing a treatment. So we don't know if this treatment is working. Okay. So it's important because patients have told me, oh, if I am not in that trial, I will not receive the therapy. No, you are not going to be tested, but doesn't mean that the therapy works. So I think that it is very important to understand that not all the therapies that are tested in trial work. Okay. So that's the first thing. Second thing, of course, I understand that everybody wants to be in and wants to be easy to localize. So the best way are, of course, being registered, so being in the registries that exist, because on many occasions when a center is doing a gene therapy trial, they are going to contact the registries to identify patients that are suitable. So important that the information is up to date, important that they have, if they have information about functional information, so if they are ambulant, if they are not ambulant, how many meters do they walk, what mutation do they have, that's also important information that need to be in the registries. And I receive a lot of mails every week from patients that want to participate in the trials. So unfortunately, we cannot always include patients in our trials from other countries because there are some restrictions. For example, if a patient need to travel to Newcastle every week from Italy, or imagine from South Africa. I remember I had a patient from South Africa that wanted to participate in a study. It is not realistic that someone can come every week from South Africa to England to participate in a trial. So contacting the centers is always a good idea, of course. We have a list of patients that have contacted us, but everybody needs to understand that there are some things that are impossible. For example, we cannot include all the patients in the world, or we cannot include patients that are far away from England or from Italy or from Spain or from the States in the studies. Another important concept, the patients that are included in the studies are patients that need to be in a phase of the disease that is progressive, because we want to test the treatment in patients that can really show some differences after 1 year of time. So if we include a patient that is in an early stage of the disease or even has not started, we will not find any result. So we need to see some kind of progression. That's the reason why in the studies, there is always this inclusion criteria where we are looking for patients that have at least have some weakness. And if we go to the other side, unfortunately, patients that have lost ambulation or that they are very advanced in the disease are not included in the study. And the main reason is because probably in these cases where there is no muscle left, it is very hard to identify an effect of the drug. Good thing to say is that in the sarcoglycan studies, patients that are non-ambulant have been included. So these are patients where we are testing the upper limbs. But let's put the more extreme situation, someone that can only move the hands, for example, and requires a ventilatory support. So these patients are not going to be included in the studies now because they are the patients that we expect to respond the less to the treatment. And nowadays, what we need to do is to demonstrate that the treatment works. And once this is demonstrated, then we can start discussing if we need to treat everyone or not. But now we are in the phase to demonstrate that the treatment works, and for this we need a population of patients that can respond to the drug. Okay.
Okay. I don't know if there's some question in the chat that Claudia or Beatrice want to do. If not, I I continue. Uh,
Yes, there's Francesca Quattrocchi is asking about LGMD 2D trials.
Mm-hmm.
Like what are the main current studies and trials
So to
regarding?
yeah, well, it's what I just said. I mean, for the patients that have alpha sarcoglycanopathy or gamma sarcoglycanopathy. So in the sarcoglycans, we have, as you know, alpha, beta, gamma, and delta. So there are trials that are being planned now for alpha, beta, and gamma. With the beta is the trial that is more advanced, where we have a phase 3 clinical trial with the emerging. With the alpha and the gamma, with the gamma sarcoglycan, we have the study that Atamayo is doing, is the phase 1. The phase 1, I think, has finished, and they are now planning a phase 3 study. And Sarepta is going to do a phase 3 study in gamma sarcoglycan that hopefully will start this year. And with alpha, there is a phase 3 clinical trial from Sarepta that is going to start hopefully this year, if not next year. And Atamayo is also planning a gene therapy clinical trial that will hopefully start next year. But there is not too much information about this trial. So I can tell you that if we can, we are going to do all of them. But there are other centers, for example, I know that in Italy, probably in Milan, they are going to also do one of the sarcoglycan studies. I think is the gamma sarco that Atamayo is doing. But I don't know about other sites in Europe or other sites in the States, because this is information that is confidential of the companies.
Okay. I have a question. What is known about emerging in Europe? Are Sarepta planning to open centers? Are there already any included? And what criteria could one participate? Thank you.
Yeah, Emerging is now close to recruitment. So Emerging is a study that was planned to recruit 16 patients, and the recruitment has finished. So all the patients have been included, and now the company is analyzing the results. So there are no new centers in Europe for now. And then Emerging, as I said, it's a smaller study with just 16 patients. So I don't know if Sarepta is planning to do a bigger study in beta sarcoglycanopathy. If they do that, probably they will communicate this to the patient community in the next months or year, and hopefully they will open sites. But for now, what they have done is this study emerging that is now close to recruitment. If I want to show, because I think that many, of course, I understand that you have these questions which are very relevant, but as you can imagine, it is very hard to have up-to-date information. So I guess that most of you know this webpage that is called clinicaltrials.gov. For those that are not familiar with this is the webpage of the US government where many of the studies are registered, for example. And then you can then come here, for example, and say sarcoglycan, and then you click, and then you can see here that are all that the studies that are registered are all listed. And for example, I can click here, I see clinical study of gamma sarcoglycan gene therapy to see, and then I have information. This is the phase 1 study that was done by Geneton. You can identify here the product that has used and the location, the place where the study was done, only in France, inclusion criteria, blah, blah, blah. Sometimes they also include some results. So if you want to know more, you can sometimes just copy this and paste it. That's what I do when I want to know more. And here you can also see results, sometimes newsletter that for example, you see here the newsletter that the Geneton did, encouraging results in a phase 1 clinical trial in Limb-Girdle Muscular Dystrophy type 2C. This is an old document, you see 2012. But I think it's an easy way for patients that are, as Carlos was saying, a bit anxious about the therapies. If you want to know if there is any trial, just do what I had done. Just go to clinicaltrials.gov, try to find the job, put your disease, and you will see the studies that are open.
An important thing, Jordi, I think in the clinical trials.gov, you can have the translate. So even if somebody don't know English, it can translate immediately the page in Google make it like that for you, and it's very
Yeah. So the data there
useful.
is not always updated. I mean, of course, it's not always that they have data, they change the data every week. But I think it's a good way of being up to date. And it's also a good way to know where the studies are going to take place. And also to see studies that are maybe not clinical trial, but are also academic. So I am an academic. I do research as Carlos does, and we do research in these diseases. And when we are doing a research in, for example, sarcoglycans or in other diseases, I also register my studies there. And then this way patients can contact me and tell me, oh, doctor, I have seen your study, would like to participate. And it's a good way for you to know what other studies are part of clinical trials are going on. Because as I said, it is very important to also understand how the disease progress, biomarkers, muscle function tests, the natural history of the diseases, etc. And not everything is industry. There are many academic studies as well.
Jordi, I have another question, and it's about you before mentioned that in many of the things that we know is thanks to the Duchenne research, no? But this Duchenne research, it have already some drugs that are approved.
Yeah. Mm-hmm.
So some of these drugs that are already approved can be used for Limb-Girdle, or it should have they should have to pass again all the process of the clinical development until they demonstrate that it works for Duchenne.
That's an excellent question, Carla. So you have two different types of treatments. So there are the treatments that are specific of the gene. So you have seen here, we have discussed today gene therapy, and you have seen that in gene therapy, we need a healthy copy of the gene that is lacking. So in Duchenne, of course, the gene is called dystrophin, and the gene therapy in Duchenne is just having the dystrophin gene. So if I inject a patient with sarcoglycan, a gene therapy with dystrophin, nothing is going to happen. So you need to develop disease-specific treatments. And all the gene therapies disease-specific, okay? But that there are other therapies. And I'm going to put an example of givinostat. No? Givinostat, it's a molecule that I have not discussed today because it has not been studied in Limb-Girdle. But basically what givinostat does is that increases the regeneration of the muscle. So it's more or less kind of an anti-fibrotic drug, but a part of reducing fibrosis also increases regeneration. And then the company, it's an Italian company, Italfarmaco, did the study in patients with Duchenne and then demonstrated a moderate effect of the drug in Duchenne. And because this is a general mechanism of degeneration, this drug could be effective in other diseases. The problem is that these drugs are expensive. So no one can pay. So if you go and pay for this drug, it is very hard that you can keep that. And the governments, before authorizing patients with another disease to be treated with this drug, want to be sure that this drug is also effective in other diseases. Why I'm saying this? Because in Duchenne, you have a very high and very intense process of degeneration. And maybe in this disease, this drug is effective. But in dysferlin or in ANO5, even in FKRP, the process of degeneration is much slower than in Duchenne. And maybe the drug is not effective in these processes. So before testing these drugs, or before prescribing these drugs, we need to be sure that the drug is effective in a new disease. Of course, if you test the drug in 3, 4, 5 different diseases, then you can assume that all the muscular dystrophies will respond to this drug. But not because it works in Duchenne means that it works in other. And it's the same with the steroids. You have seen the slides, right? So steroids are effective in Duchenne because there is a lot of inflammation. In sarcoglycans, there is inflammation, but not a lot. And therefore, the results of the steroids are not so positive. Patients have been treated, some can respond, but many do not respond at all. So it's more or less the same situation.
Thank you. I've got another question. A patient with LGMD2C tells us that for the past 2 months, he has been regularly taking 2 sugars, limonose and ribose, morning and evening. He claims to feel better. These therapies have been recommended by an Egyptian doctor who suggested that those sugars might help misfolded proteins avoid degradation and reach the membrane to perform their structural role, even to a lesser extent. The doctor's hypothesis is that mannose could act as a competitive inhibitor of mannosidase 1, which plays a key role in the fate of misfolded proteins. Nothing was mentioned regarding ribose. As a medical researcher, what do you think about this kind of therapies? Have you ever heard about this? And can you provide any insight? Thank you.
Yes, that's an excellent question, and not only ribose. There are other treatments, like for example, there are patients that receive coenzyme Q, or there are patients that have received alanine or other amino acids that are also trying to supplement the amount of proteins that are present in the membrane or the muscle. And I always say the same. This seems very interesting, and it is possible that these drugs have an effect in patients, but I, I think that we scientists need to demonstrate things in using the scientific method. And the scientific method means that you need to do a study where you have patients with one condition, and then you treat some of them, and you compare the treated with either untreated patients or with historic controls. And I think that we need to be very serious on this and very professional, I would say, because we need to either know if the treatment is safe first. Second, know if the treatment has a real effect, because of course it can happen that one treatment has kind of an effect or a mild or moderate effect in one patient. But is this something that we see in all patients? Or it's just happening in one patient because there is a coincidence, or the patient is really enthusiastic about being treated with something and then feels better. That means sometimes that feel less fatigue or feel that has less pain. But then when we try to objectivize the response, we don't see a real difference. So of course, all these parameters need to be taken into account. And I always say the same. So for these new molecules, of course, there can be a physiological basis, mannose, as you have mentioned, but for example, the amino acids is just supplementing the muscle with proteins, or for example, coenzyme Q can be putting like a push of energy, anti-inflammatory drugs the same. Let's do a trial. Why not? And then with the trial, then you see the treatment is effective or not. And I understand that trials are expensive, but just to say they are public funding that we can apply if we have data to uh, try to do a trial with a drug. So if the doctor is convinced that this treatment is effective, this doctor should try to do a trial to demonstrate that this treatment works. This is, I think, the scientific method. And I defend this method. I am not in favor of prescribing medication to the patients without having evidence that the treatment works.
Okay.
Thank you. I've got another question. Is there any hope for a cure for FGMD2A? And if so, when?
I see the question here. Yes, as I said, Sarepta is also developing a gene therapy. Sarepta and Atamayo both are developing clinical trials for Limb-Girdle Muscular Dystrophy 2A that hopefully will start in 2026. If not, maybe 2027.
Okay.
There's something also important that I want to mention. So you see here, and let's play another game, which is we are talking now about a lot of gene therapy trials. And if we talk about how expensive a gene therapy trial is, I think this is something that also we need to put in the table. So these studies are super expensive. It means that companies are investing millions just in running the studies around the world. So as you see, there is a risk for companies that are doing 3, 4, 5 trials at the same time, because this means that they are putting a lot of money to run the trials. But if the trials fail, this means that they are going to lose a lot of money. And that's one of the reasons why you see that they don't start the trials all together at the same time, not only because of the production, but also the expenses. They need investors, but they need also that one of the trials works. And then to be able to show that the treatment is effective, the strategy is right, they can commercialize, they can start having revenue, and this revenue support other trials. So the Limb-Girdle 2A is one of the diseases that is in the pipeline. It's coming 2026, maybe if not 2027. But of course, there is hope for patients, at least to have a trial. And as I said, we don't know if the treatment works, but at least to have a trial.
Okay, thank you.
Okay. So I think we have many other questions, but they are all very specific. So maybe we can take all these questions and we can try to answer or to give it to you in a future. I mean, because now it's like 1 hour and 15 minutes that we are talking. And I'm gonna also remember to the people that this presentation gonna be put it on the web on our channel, and there you people can have it and look it very slowly and go forward and backward and then try to translate, and we will have a clear situation on of the trials and this. So I'm gonna thank you, Jordi, to this nice presentation and to the dedicated time in the name of GFB. And if we receive the questions, we're gonna contact you again. Thank you very much.
Thank you very much, Carlos, and thank you everybody for
Thank you.
listening
Thank you,
today. And I wish you the best. Okay.
Thank you very much, Jordi. Thank you to everyone who has attended and was joining us. So thank you so much. Thank you.
Bye.
Bye.
Bye.